Hey guys, Don here. Welcome to the $1 Million Minute, where I'm going to go over kind of what I've been doing to help get the practice to the $1 million mark and beyond. Yesterday, I did an interview with Marco. If you haven't listened to it, it's in the podcast. It was a really good interview. I guess the main takeaways from that interview was he has a virtual assistant that when patients come in, he recommends certain high level like treatments. So MLS, laser, shockwave, things like that. And he has a tracking sheet. So he tracks if they accepted it or if they didn't accept it, and the medical assistant calls them just to follow up. I thought that was a really neat idea, something that I certainly am not doing, but I like the idea. Another thing that he does is he has a patient tracker list. So every patient that comes in, they put them on this Excel spreadsheet, and they make sure they have a follow-up or have done a follow-up. So I think it's just a way of making sure that you don't have a leaky bucket. And that's a term that I learned from Dan Kennedy, where you have these patients, and if we're not following up with them because we all get busy, it can be a difficulty for us. So something to maybe consider. Listen to that a podcast. You might like that. Kind of what's going on in my life. I had some bad news yesterday. My dad lives in South Dakota, and he had a fire. So he's getting a little bit older, a little bit of Alzheimer's. So there might be some big changes in my life. But so that's the way life is. So I always like to share kind of what's going on here right now. So let me go over the day. So there were a lot of patients, but we had a little snow day here. So we had our first snow in Massachusetts. So some patients canceled. So let's go through with this. A patient was a IND bilaterally for ingrown toenails. No follow-up. I try not to do follow-ups nowadays. For regular INDs. For matrices, I still do. There was another patient got x-rays for a Cavus foot and a neuroma. I recommended more anatomic shoes, and they're only going to follow up as needed. Another patient was a new patient that had burning pain to the arch region. So she had a Cavus foot. She had a neuroma in the third interspace and with a Mulder's sign. So we did x-ray, we did ultrasound to show her the neuroma, and we did a cortisone injection, and I'm not sure when she'll need to come back. She's going to Florida, one of the snowbirds here, and so she's going to come back as needed, so no follow-up for that one. Another patient came in. This was an orthotic follow-up. They're doing much better, so we're going to do a 1-year follow-up. So those visits, I'm not really sure. I was kind of thinking of ways I can reduce those, because as long as the orthotics are fine, it's not really the most profitable visit. I had a good idea, or I heard of a good idea when I was at the last practice AAPPM meeting, is they have a podorthist, and this podorthist dispenses all of their orthotics and dispenses all their AFOs. And I thought that was kind of a neat idea, because for me, it's kind of a lower level visit, and maybe someone else could do that versus me. So I like that idea. I am not doing that, but I just thought I'd share that idea with you. There was another patient that he was here. She had a fracture, and she had a phalanx fracture, and I was seeing her at I think this was like 6 weeks after. So what I try to do is when I do a fracture code, I try to reduce the follow-ups. I know you can get the x-rays and get those paid, but as long as everything's stable, I try to just do one follow-up. So it's kind of better for me that way. So just something to consider if you're doing fracture codes, kind of just doing one follow-up. And she had transitioned out of the cam boot, and she's doing much better. Another patient with an IND of the hallux. Another patient that came in for a fracture. She had a fracture of the distal phalanx, x-rays, and I put her in a cam boot. And then she was feeling actually so good for this one, I am not going to see her back, because I think it was a non-displaced fracture. I think it's going to heal just fine, so that one I'm not following up with. Another patient that came in with a brace follow-up, she has a standard AFO because of a previous traumatic event on the right side. And she has like a tibial rod in, and she has just a lot of like kind of nerve pain. And the AFO is fitting fine, but what's really bothering her was the neuropathy pain that she's having, and she does have diabetes. So I'm going to try to get her covered for Cenza. So that's what we're going to do, and I'm going to see her in 1 year for the AFO unless the Cenza is covered. And that's something I just send a note to my staff, and they look at that. There was another patient that came in with right foot pain. He was a young kid, 25-year-old kid, kind of a runner, having some foot pain on the outside. And really for him, I think it was just shoe gear. I talk all the time about shoe gear, and so I recommend an anatomic shoe. If you don't know kind of my shoes that I recommend, I have a shoe buying guide if you want to take a look at it. If you go to centralmasspodiatry.com, go to my blog, and then on the side you'll see the shoe buying guide. So you can kind of see my guide that I give to patients. It kind of talks about kind of the philosophy I have on shoes. Feel free to use it. Don't steal it, but feel free to use it if you find it would benefit your practice. Another patient came in for EPAT. Now, this is interesting. This patient, she was a 51-year-old female. She has a lot of other things, and she was on a certain medication for her asthma, and it was an injectable medication. It's a new one, and it caused joint pain all over the place, and even her second, I think it was like the second metatarsal head pain, and that all went away when she stopped the medication. So I actually did not do the third shockwave. She had prepaid, so I refunded her. So that's never happened before, but it's kind of an interesting thing. Another patient came in for an orthotic follow-up, had a new pain to the Achilles. Now, this was interesting. So pain to the Achilles for 5 days, quite painful. She has a spur back there, did an x-ray. And for this one, I don't normally do this, but I put her in a walking boot because it was so flared up. It was only 5 days. I gave her an anti-inflammatory, and we'll see how it goes. In 3 weeks, I'm going to see her back. I didn't jump right to the shockwave because it was only like 5 days. It wasn't like a chronic thing. Hopefully it'll just calm down for her. Another patient came in. This is a 56-year-old man. He was, after plantar fasciitis, he was treated, got much better, totally better. And then I was kind of teaching him about his foot and things like that, and talking about the importance of a high contouring orthotic to reduce the pull on the fascia to prevent recurrence. And then he opted for an orthotic. So that was my one orthotic of the day. And I think that would probably be my MVP of the day, really, because that was the only orthotic I did. Another patient came in. This is interesting, and I think you heard about it last time, but she had a previous barracuda bite from when she was in Cancun. And she had a big scar around her foot that got sewed up, but now she's having scar pain. And so I have a Cutera laser that I work on scars sometimes, and so I usually do 4 sessions, and I heat it up, and I kind of feel like it kind of realigns the scar tissue. And she also uses Mederma, and she uses tape on it to help reduce the pulling. So that's kind of a unique one. Also, there was another patient that came in. It's interesting. He had a hip surgery. He was from Boston, but he flew all the way to Chicago for a hip surgery. And it just goes to show, like, if someone really Googles and looks and wants to see you, they'll travel from wherever to see you. So I don't know. I've had a lot of patients come from, not a lot, but a couple from New Jersey and New York because they see stuff online. And so this guy went there for a hip surgery. He couldn't get down, and he had some heel pain, and he thought he stepped on something, but really it was just a wart. So we talked to him about Swift, but we started him on cantharidin first. Another patient that came in, this is kind of an interesting one. She had swelling on the 4th digit dorsally around, like a tenosynovitis around the extensor tendon. And it was fairly recent, and I'm going to see if it kind of calms down. If not, I talked to her about doing a cortisone injection in that area. There was also a patient that came in for a nail avulsion. So this was one that we did a partial nail avulsion on the side, and then her nail was a little onycholytic and detached on the half of it. And it was still painful because I think it was moving, had some micro movement, and that was injuring it at the base where there was swelling at the nail, kind of the proximal nail bed. And so I just did a partial nail avulsion, so pulled off half that toenail. I didn't want to do the whole thing because the other half was still in good position. And then also there was a patient that came in for an orthotic dispensing and a follow-up. And so since they got their orthotics, they're doing much better, and they're going to be in for 6 weeks. And then finally there was a Lamisil booster that I did. So the last thing I want to talk about is I was talking to Marco, and I would like to know if anyone listens to this. I know there's quite a few here. He says he gets great success with Lunula. Now I have Lunula, and I tend to talk people more out of Lunula than into Lunula just because I don't find it works as good as Lamisil. But he was quoting a much higher percentage. I would like to know if you guys use Lunula and you're like, this is as good as Lamisil, let me know. I just don't see that. But if someone else does, I want to know what I'm doing wrong. I'm thinking, like, because I could do the Lunula. I do weekly sessions, like 4 weekly sessions, and then a month after, then another month after. I don't do a topical, so maybe I could add a topical. I guess he does some soaks. I don't do soaks, but I do the shoe stuff. So just something to think about. I would love to know if it worked, because if it worked, it would make it much more profitable for the practice, and I think patients would like it. I just don't like having those conversations. Hey, I'm sorry, the Lunula didn't work. So if you are a Lunula rep and listening to this, let me know. I have the Lunula. I just don't use it a ton. But if you guys do, let me know, okay? Send me an email, don@podiatrypracticemastery.com. Okay, thanks, guys. Have a good one.